You don't have to talk. Thanks, everybody. Maybe at the end of the talk, we'll say something. So thank you for being with us. Our work here, our shared work, along with Ketco, who I want to acknowledge in the audience, the important part of bringing it together is really about, like we say, building capacity, laying the foundations for getting to the big questions that big data will enable us to do. And in order to get to that point, we had to build some understanding about what are the common challenges that are standing in our way to get to that point, and how do we come up with a way to negotiate around those challenges. And the critical questions that we want to at least set up for you here. First, there is a reason for us to share data across institutions in the spectrum of medical education and health professions education more broadly. But in order to do that, we have to identify what are the challenges that I mentioned, technical, structural, but also some of the conceptual things that we're going to discuss. And lastly, what we hope our work does in terms of the consensus work is offer some solutions to find our way and navigate those tensions.
So I don't think any of us would be here if we didn't believe that exceptional education is a core pathway to exceptional physicians, exceptional healthcare workers, and better health for our communities. And as education scientists, we recognize a responsibility to try to understand the relationship between our education policies and practices and the healthcare that's delivered to our patients and our communities. But for those of us that have been working in this area, we've often come to recognize a major difficulty or major challenge in tying these two ideas together. The data that are available to create these links are not necessarily easily accessed, harmonizable. And we run into this issue of trying to build up these arguments. Now, there are some good examples where the data sources that are available pertaining to the education practice and its relationship to healthcare do exist. Well, we have seen this research. Look at Ash's really wonderfully titled paper, How to Deliver a Good Obstetrician, is a good example of showing how the quality of medical education training is related to maternal complication rates. Rodney's Hamlin here in Canada did some great work looking at the performance on the Medical Council of Canada qualifying examination and its relationship to professional complaints labor and practice. There's work in the simulation world, Jeffrey Bartlett's on infection rates and mastery learning. But we only have very, very few sort of examples. So as Mohan and I have been thinking about this with our colleagues, we've really been focusing on the system of college change. This idea that better admissions, better curricula, better forms of assessment will lead us to matriculate a stronger group of students that will lead to the graduation of a stronger set of physicians and healthcare workers, and ultimately lead into healthcare. And we're trying to find ways to bring the data along each parts of this continuum together, so that we can test this assumption.
But one of the challenges is that getting data, right, making those associations with data is quite difficult. If I were the CEO of Amazon, I would be divorced but still very rich, and I'd be able to get answers to my big data questions very easily because the inputs and outputs are in a constrained system. But medical education is not Amazon, Google. We don't own like one constrained sovereign system. Rather, what we have is that people moving through a pathway, like Lawrence mentioned, in which there's lots of data at each one of these stages, from prior to admission, when they develop their prior educational experiences, their social identities, to a selection, to in training, and then of course out of the licensing and practice. Each one of these systems, or each one of these phases rather, is its own system, has its own data requirements and data system. And often the challenge here is that they sit in silos. And unless we can break down some of these silos and connect data across this pathway to go back to that causal chain Lawrence talked about, we will never be able to realize it and never be able to really interrogate it for things like value and accountability.
So there are some things, again, back to some of the examples that we rely on. we had some success in breaking down these silos, which has given way to our current work. I often tell this story when I'm talking about this data capacity initiative of our McMaster-led pan-provincial level research on predictors of success for international medical graduates, which was a study where we brought data pertaining to the IMG experience together from the 6 Ontario schools. And well, we started with just a McMaster. This is how the story really goes. We started at McMaster where we brought our data together with certification exam results from the 2 colleges, the CFPC and the Royal College. And we published this, and we found some interesting findings. English DeBoer and Matt Mercury were involved in that. And you know, I never get calls as corresponding authors for a paper, but after this was published, I got a bunch of phone calls from people, and nobody really cared about the findings of the study. Everybody asked, how did you get the colleges to share your data with you? And I didn't know. I didn't know how I was able to manage that. I think I asked at the right time and politely enough that it came together, but it led to this larger conversation where we were able to bring the 6 Ontario schools together and find the pathway that allowed us to break the silos down to create new data sets. And we've seen this in other places. Geron in the California system has done this around the MMIs. And currently, we're working again in a pan-provincial 6 Ontario medical school project, which we call ONSORT, to bring together admissions and assessment data from the undergraduate perspective and comparing it to outcomes on the MCCQE1 data. So we're starting to find our way through this. But as we're working on these projects, as we've engaged in this, these bright ideas, these light bulbs that we have above our head get broken, and we realize that we can't just be researchers anymore. That there are more processes and more ways we need to engage with stakeholders in order to realize the promise and potential of the research that we're trying to do. We need to find ways to make the work feasible, to protect confidentiality, and to encourage people to participate in a way that makes them feel safe about the way their data are being treated and what our intentions are from a research perspective. So it's sort of risen to more of a policy level consideration for us. And ultimately, the big sell when we're dealing with stakeholders like medical schools, data stewards, like the medical council or the colleges, the big sell is that folks realize a pervasive social accountability to the profession and the public to create research evidence that impacts the quality of education and, as we've said, the quality of healthcare. And in here, we've been able to draw people in and work to leverage this capabilities. So that brings us to the work that we've been engaged in since spring 2021. A little bit before that, where we've realized that we can't just head blindly into this area with no principles to guide the work, and so we've set out to engage a large pan-Canadian group of data stewards, education stakeholders, training advocacy groups, regulatory authorities. The list goes on and on. All of the groups, institutions, and individuals that we believe are safe in the medical education trajectory. In conversations designed to develop a consensus on interinstitutional data sharing for medical education research. This was a 5-part workshop series that spanned about 3 hours, 4 hours of a workshop over a few months. Where we led facilitated discussions and case reviews to distill down risks, benefits, values, and ultimately build up a set of recommendations and principles for the governance and operation of medical education data. Along the way, we've recognized the importance of including the most key stakeholder in these discussions, and these are learners, the individuals who are represented by the data that we're talking about, either aspirants, individuals that are in undergraduate or postgraduate training. And in some cases, we're talking about the graduates of our schools and postgraduate programs also pushing to practice. Key stakeholders and key engagements were made with learner advocacy groups throughout this process, including the CFMS and RDOCs, but also the Black and Local Student Association of Canada, student representatives of the Indigenous Physicians Association of Canada. I think that's most of them, and we've engaged them throughout the process in our pre-workshop consultations, directly in the workshop consultations, providing a place for them to act as an observer group and to reconcile their perspectives with those of education institution leadership throughout the country, and then in our follow-up board also. So we feel like we're very well represented in this consent.
And it's really good that we did come to consensus. So I think when we started our consultations, we also heard a lot of disquiet about this endeavor around big data. But one thing that centered the conversation was that we all agreed that there was a shared goal that we were all working towards. And that goal here is data. We're not going to read it out for you. But this was something that got all of our participants to agree. This was the collective endeavor we're working towards. And we recognize there are three sort of critical things about this. One is that education is an important part of meeting this goal. Data about education and from education can help optimize our pathway to that goal, both in terms of education practices, research, quality assurance, any of those other activities we think are important parts of scholarship. But most critical was also that people recognize and gave us lots of examples where historically data has been used in negative ways that impact learners, communities, and institutions, sometimes intentionally, sometimes unintentionally. So that while we're working towards this goal, we have to be mindful that there are these unintended consequences that we have to manage and deal with head on. So starting from this place, we started to say, well, can we articulate what the benefits we might think are around data sharing and getting towards big data? And clearly these ones were not very hard to come up with. So people said, well, it uses data for quality improvement and making accreditation easier, helping me deliver a better education program, to help demonstrate the fact that I'm meeting my social accountability mandate, or that my education is making an impact on the community that I'm intending to serve, or helping us do better research. And that's, for us as researchers, is a critical factor. It's helping us ask better questions, answer questions differently, or really to add another dimension or a lens to an ongoing research program. What was just as critical was articulating what the risks were. And we sort of think about these risks in the typology of both process risks that are pertaining to research and scholarship, and outcome risks in terms of the development of use of big data. One process risk is that you have the consequence of losing privacy or confidentiality of someone represented in the data. You can imagine bringing all the data together. You can come up very quickly, even in a data set is supposedly de-identified, a way to re-identify an individual. The one left-handed surgeon who is from Canmore working at McMaster. That's data we can put into a big data system, even if we don't have their name or any other sort of personal identifier. The fact that sometimes this data research happens without consent, that people don't recognize that their data is being used to answer research questions or for purposes beyond which they reasonably expect it to be put to use. Data sovereignty was a critical thing that came up in these conversations. In the broader context that we want to look at this term, it's really about disassociating and using data from the communities in which it is gathered and the governance and practices that look after or regulate the use of that data. In a more Canadian context, if you think about data sovereignty as it applies to Indigenous communities who have long struggled for and fought for the right to have a say in how data about them is used to benefit or advance their particular agendas or concerns. And so this is a critical concept that is now often part of research ethics practices that can be violated if we are not mindful that data sovereignty is a critical concept for doing ethical work. There are also outcome risks, which include using data for discriminatory purposes to limit the autonomy of students. This is one we've heard quite a bit of, saying, you're I'm gonna use this data to stream me into this pathway or this specialty because that's what everyone else, or that's what the data said is most right for you. And we can avoid potential misinterpretation or use of data in ways that often happens even without big data research. That people take the wrong conclusions or inappropriate generalization from a conclusion. A new one for me was a concern around interinstitutional comparison. In our data, multiple institutions get represented, and we're looking at different benchmarks and saying, oh, this is, institution A is worse than institution B. And that institutional reputation is a real risk and will prevent institutions from sharing data across the system, which, is a huge barrier for us to get to our goal of having shared data.
As we were working through the risks and benefits towards some recommendations, it was apparent to us that when thinking about a sort of a pan-Canadian multi-jurisdictional reality, that Mahan and I weren't developing policy, that we were looking for principles to guide research through interinstitutional researchers, through interinstitutional data sharing processes. And that realization gave way to the idea that we needed to establish a shared set of values that all of the stakeholders and stewards agreed were to be foundational to whatever principles we landed on. And that gave way to six values. The first was that we need to conduct this work with respect for informed consent. We recognize that, and we're sure to get questions about this in the Q&A period. We recognize the challenges inherent to developing, sort of a standard informed consent process for big administrative education data research that might be retrospective in many ways. And have offered some recommendations about how that might be managed in a meta consent or a time limited way. That the work needs to be non-discriminatory in its very essence. That we need to conduct research that doesn't violate commitment to learner autonomy or community autonomy, meaning that we shouldn't constrain individuals or communities' rights to deliberative choice about their education, about their training, about how the research inputs are used to serve their communities. We need to respect privacy and confidentiality. I think that one's pretty straightforward. And then the last two were really interesting. Is that we needed to really commit to appropriate research purposes. That the idea that opportunistic research that just aims to leverage infrastructure to increase our productivity as scientists enhances the chances that the risks that we described will be realized. So this work needs to really focus on established problems and issues in the medical education environment, and to be producing outputs that matter for affecting change in those spaces. And that we also need to be mindful of engaging in appropriate data collection practices. So as we start to think about a lot of the research we do in a qualitative interview or building a survey or we're collecting some data, a lot of times we say, well, why don't you just collect this variable too? We don't know when we're going to use it, but we might as well ask that question or have that survey thing there. We want to avoid a situation where medical schools, postgraduate programs, and other start collecting data that's tangential or ancillary to the core education mission of that program. Again, to avoid the accentuation of the risk inherent in this type of work. Oh, wrong way. So we've started to come up with a set of recommendations, three core recommendations for this work. And the first one is that the research needs to be conducted with guidance from an Evolv governance structure. This governance needs to be dissociated from the research team and needs to be comprised of individuals that are staked in the data collection, representatives of the institutions or the learner groups that are represented in the that is necessary to offer guidance and oversight to our adherence to the values and that have been given to us here, along with our research evidence approval and whatnot.
And serve an additional function beyond just that additional function beyond a standard R&D, which has the expertise, this body would have the expertise and ability to look at the risks and that we've articulated and say how these are being mitigated and how these can be managed by the research team. The other thing that will help facilitate this, and we recommend or conceptualize, so these is somewhat independent from a governance structure, is having a facility that could be trusted to do data management, that has an arm's length relationship to both parties, but has the expertise and capacity to bring data together, disaggregate data, sometimes de-identify data, or delete data, or destroy data, as the case may be. And importantly, this body has the function of performing quality assurance and quality improvement on data sharing projects or data sharing relationships that have been established and governed by the governance body.
Yeah, and I think an important point to emphasize when we talk about both the governance structure and the data management facility, these trusted groups that we're referring to, is that we're not pointing specifically to a governance body or a data management facility that would serve all Canadian research projects. That these might be locally understood and locally developed or conceptualized in the context of any one project. That they're essential components, but they might look different here than they do at University of Toronto or in Alberta, or if we're talking about something that's sharing data coast to coast. That these are structures or ideas that need to be present, but there's flexibility in how they're understood. The last recommendation is to push the community towards a common set of data management standards, and this is really in line with a push from the Tri-Council and their new data research management policy, which draws our attention to the institutional strategies that exist within our university context. The idea that we make consistent data management plans that we can follow and guide our research, and that we're contemplative of data deposit and how we make data open source for follow-up along the way.
Our initial funding for this sure-funded exercise is really to evangelize, I guess, that there is a policy the Tri-Council is putting out, and it's wanting people to sort of respond and engage with that. This has been an interesting opportunity to go beyond, I think, what the policy said, to actually say, how do you build quality in a policy for data governance? How do you build accountability to all the issues that we've raised? But certainly, I think at minimum, having a conversation about what data standards are and what policies need to be in place.
Yeah, and this moves us closer as a sort of disparate set of institutions to interoperable expressions of data, consistency of the way we collect and report. In our own research, it's been a hell of a time to line up one variable with another at each school, even though we are presumably measuring very, very similar, very, very similar things. So
Not really common, similar curricula as opposed to vast differences.
that's right. So part of our work also elicited a series of 7 governance principles. So we talk about this governance committee, and in here we're able to highlight the ways in which we think that they should be constituted and interact with each other. How we define who should be represented on a governance committee, what their role should be relative to other approving bodies like ethics boards, and to emphasize that this group has an obligation to the values, the recommendations that I'd like to say that we're putting forward, but really these are much different ideas than Mahan and I figured we would land on when we started this work. That this really is a constructed consensus that represents the input of all the players in the context.
Can I draw attention to one thing?
Yeah.
Principle number 6. This was an interesting point of learning, I think, for our community to think about research evaluation and quality improvement in the same way. And the reason for that is in our analysis, the risks because of data sharing in terms of any of those goals are very similar. And as such, we thought the principle applied to all of these activities, which is very different, for example, from a traditional ethics regime, which might say some activities are exempt from ethics review because you're doing them primarily for quality improvement or research. From the perspective of the learners who might be centered in those endeavors, the risks are still the same. And so we thought this was a interesting learning and reflection for our community, where in other jurisdictions, for example, a lot of medical education, what we might term research, happens under the aegis of QI or other types of governance structures and not really subject to ethics review. Where do we go from here? I guess is on this slide. Well, I think that's the conversation we're hoping to have with all of you. You know, we always say that the implementation is beyond our pay grade. Certainly mine. I won't speak for Lawrence here, but we've made some progress in terms of dissemination and implementation.
Yeah, so as I mentioned, we're currently involved in a Pan Ontario a project to bring data together, where we are applying the very consensus to the way we operate, and it gives us an opportunity to feel how this works and to be responsive to a governance structure, to engage with a trusted data management facility, and to be thoughtful about our research data management plans. We have had the opportunity, as Mohan said, to share our consensus work with folks like you, but we've also taken this consensus document, up and down the block, really, and knocked on all the doors of all of our stakeholders and had an opportunity to sit down with them and to encourage their endorsement. And we've heard positive response from these groups who have gone back, the AFMCs, the CFPCs, the Royal Colleges, the MCCs, et cetera, who have gone back to their constituents to discuss this work. And we carry on with that and are moving some of these ideas forward into international consensus conversations. How do we get outside of this jurisdiction of Canada and start thinking about the use of administrative education data across borders? I think this is what we just said. Speaks for itself. Yeah. So, thank you. We have lots of people to thank. So, we have Kestrel McNeil in the room, who was a facilitator and a collaborator for us. I'm not sure who's online, but Brett Button or Rochelle or Ala or Alice are there. You can turn your cameras on and wave to everybody so that they can thank you for your help. Our colleagues in the Ontario Medical School Outcomes Research Consortium, we're very grateful for their support and their input. We can't go much further without acknowledging SSHRC and their funding for this work. But we've also received funding from a few other places, including Mahan. You can do your own.
Yeah. Department of Family and Community Medicine at UT, and the temporary gift from the Temporary Family at the Faculty of Medicine at the University of Toronto.
And we're currently funded from the Digital Research Alliance of Canada, and we've got Ronald in the room, so we'll thank you also for funding from Ontario supports and work dissemination. So thank you.
Thank you very much, guys. I could talk about this today, but I won't. Except to say that I think the apparent sort of opportunity for the consensus work that you're finding to help shape and inform the TPS policy is a really fascinating area that we should sort of talk about some more, because this idea that quality assurance work and QI work is a human participant research and therefore doesn't fall underneath the TPS policy it's a conversation that I've had several times, and I think there's a really interesting opportunity to kind of help maybe shape this, particularly in the context of what's happening at the institution around developing the new IDM policies and the type of policies.
Yeah, so we really realized when we were working through this consensus that we weren't beholden to, historical ethics policies about what's in and what's not in. It really wasn't our focus. We were trying to elucidate and illuminate where the risk lied and where the benefit lied in interinstitutional data sharing. And we recognized that the risks that we put our fingers on were there, regardless if you called it research or program evaluation or quality improvement. It didn't matter. Those represented by that data, whether institutions or individuals, we're still at risk of being treated unfairly.
Okay, Lawrence and I are not ethicists, we're ethical people, I think, we could turn a dollar if we saw a fall on the ground, but we had help in this endeavor, right? So we had learners help us understand this process. We had trained ethicists like Lisa Schwartz from McMaster, help us analyze this problem. And of course, in the education literature broadly, in the clinical literature, this is an issue that's been really talked about. And there's other fields beyond health professions are a little bit further than we are in the analysis of these issues. And we drew heavily on that literature to help us frame this understanding, which is a new understanding, I think. And something I thank you for highlighting that.
Yeah, it's certainly not something that we didn't hear from our constituents, like people involved. Many people were of the mind that we should keep these things separate, and we had to find consensus in there. Dr. Norman.
You've spoken of data and databases and ethics and principles and governance and all that in a very generic sense. In this limited experience I've had, one of the thorniest challenges in facing you in creating a large database is kind of to prejudge the kind of questions that you might be asking 1 or 5 years down the road so that you have the right data to get them. Can I ask you to sort of embellish that on, first of all, what kind of questions are you interested in asking? And I could take an educated guess, but you're obviously better informed than I am. Secondly, how did you get into this in the first place? And how did you two match up in terms of these interests in these broad domains? And the final question is, how generic are they? Even things at the level of having had the recent ugly experience of trying to reformat an Excel spreadsheet, coming out of a similar department in a similar institution. Everybody here knows what I'm talking about. Are there generic principles around, for example, data management that apply across the board for us to reach somebody over the head and say, here's how you put an Excel spreadsheet together?
Can we take a little reverse?
Yeah,
sure. So let's start with that one. That one is a surprisingly easy one, but sorry, I should say it's the answer is clear. Implementation is not so easy. Rather, there are many examples of data standards, both at the principal level and at a level of greater degree of specificity that have been articulated in the data science literature. And some of those are education specific about how do you, what makes a good identifier. Where is a good place to store data? What type of relationship should there be between variables? How do you do an analysis of your data assets to come up with an inventory and then evaluate them clearly to say, are we ready to do research or inquiry with this, or are we not? Where do we need to go? So the conceptual, and I would say the technical tools, and definitely the technical expertise are out there. Bringing them into the conversation is part of the reason we're doing this work. Because when we talk about big data, and certainly when I'll speak for myself, when I started this, bright-eyed and like, oh yes, push a button, get all the answers. But that's not where we're at. And actually, more importantly, it's only now, I think, becoming recognized by the people who are routinely managing and collecting this data at the level of the education leadership, the education administrators and education systems, that this is a potential opportunity, but our infrastructure expertise is not there yet. So that was one of the reasons we opened this conversation. And as a knock-on effect of the work that we collectively engaged in, we've had an opportunity to have conversations at our home institutions about what makes good data management practices, what is good data, data hygiene, how to source data. Definitely shouldn't be on Excel spreadsheets in someone's computer, and then when they leave or when they're on vacation, no one can access them. And there are all sorts of things that happen for expediency because no one's thinking about the inquiry that this data can support. And so going a little bit further, I also think that's why it's really important for us to work through, here's what our shared goal is as a group, this is what we want to work towards. And this is the type of inquiry we think supports it. So that was a benefit. So I don't know if that answers your question, but I think that's my take on it.
Yeah, and then further to that, Jeff, I see your hands going. He asked 3 questions. We can put that on. So further to that, there's actually a big university to university push around more robust research data management plans. So the Tri-Council policy is being enacted here at McMaster University. It might not have made its way all the way down to there yet, but the Health Science Library will have resources available that you can provide to your colleagues and departments to set research data management plans that adhere with the institutional data strategy. Our research group is starting to do that a priori to new data collection. This is a little different because a lot of this data is already extended in systems. So that's out there. How did we come together? Let's leave that one. Later here. My experience was that these questions came about because I was trying to ask a different question. You know, I was interested in this idea of predictor success for international medical graduates. And you know, I was sitting there and I was talking to colleagues and collaborators, and I said, well, you know, why don't we just take the data we have at admissions and load it against the college data sets, like naively, you know, and then I called up somebody, one of the colleges, and they said yes. And then I said, well, the other college said yes to the other college. And then, you know, and then I got them playing off of me. That's not what happened. But, you know, we asked and, you know, and it came about, but I just recognized like my sort of orientation to this work, to education work, is that, you know, it's got to matter, right? It's got to be, we got to pursue the questions that are going to make a difference for meeting this shared goal, and finding ways to bring the data together, you know, was an obvious imperative. And who's better to work with Mahan? Yeah, and so we've got a consortium loosely called the Barcelona Consortium, a romantic name because we had the conversation in Barcelona the first time, 2015. And you know, so it's just the group of us that recognize this, and we were able to.
I think all credit to Lawrence, though, who's been spearheading a lot of the implementation for the consortium. You really recognize that this was a gap. So as a result of his leadership, we've been able to, like the Comm data sharing agreement, for example, needed to be updated because this type of thing wasn't even conceptualized. And you know, it's never fun dealing with legalese as a researcher, right? Or dealing with those issues. They're not part of our training. Not that there's anything wrong with my training, Dr. Norman. But you know, these are new skills and things that you know we recognize that we needed to bring in, and then Lawrence really did the hard work of saying, you know, let's actually set up a governance structure because there is no governance structure, so we need that. And one of the insights around this is that we imagine big data research is going to be easy. It isn't, and our goal is not to make it easy necessarily. Like it is going to be hard work, but it should be conceptually clear what the process should be in order to do that work. And our experience has been that if you tell people here is the process by which you're going to engage in this inquiry, then people will follow the process because the process is clear. Everyone agrees it's the process, and these are the checks and balances involved. In the absence of that, and one of the things we really heard from a lot of people in our consensus consultations, the status quo is not a good place to be in. Because people are doing this willy-nilly without any accountability or oversight, sometimes asking questions that we might consider to be harmful or unethical in a particular perspective. You know, for example, if someone decided to do an inquiry and say, let me look at the outcomes of this particular group of trainees from this demographic group in the medical school curriculum, with good intentions of trying to make the school curriculum, they may not have engaged those trainees or that community in helping frame that question. And so there are a lot of unintended consequences we wanted to avoid. In terms of, you know, but those are questions we do want to ask at some point in ways that are ethical, grounded, and protected. And, you know, the predictors is a place to start. We're really interested in looking at the MCC as a good, high quality benchmark that has a great deal of rigor and validity evidence to look at our own practices and say, hey, this is a common benchmark that we can learn from each other. And already, like I've said, at our schools, there have been incidental learning, but more clear outcome learning now that we're gone to the data analysis stage.
Yeah, lots of folks do want to ask questions about the relevance of social identity to performance in the system. There's all sorts of viewpoints on this. This is a place where we've strived to create more clarity for folks. I'm hesitant to answer the question of what are all the questions we want to ask. I think that what I'd rather do in this time is to put that question back to all of you. You've come here presumably because you have interest in this type of research. So you'd love to hear what kind of questions people think that this type of data sharing is amenable to.
First, congratulations on this. This is such a significant amount of work. I think really advances the health professions education community. So thank you for doing that. My question is really around an experience that I've had, I think others have had, with the challenges of getting organizations to agree to data sharing. And so beyond here's best practices that we should incorporate in our own work, I'm curious to know who's part of the consensus, or I guess we call it the Barcelona group, and do they, and are those stakeholders now willing to start to engage? Is it, I imagine it's probably not go live right now, but there's a process, but I can think of an example recently from like the last 5 years where all postgrad deans from across Canada actively refused to share data, even following no principles were in place at that time, even following what might have been anticipated best practice, or even to engage in the discussion. So I'm hoping that your hard work is starting to break down some of those barriers, and your consensus, people representing the stakeholders in the consensus process are representing a changing attitude in organizations, or am I being more Pollyanna in that way?
I think that there are, my sense is that individual to individual, there's enthusiasm about this work. Organization to organization, it's a tougher knot when we get to the institutional level. First point of clarity, the Barcelona Consortium is a group of researchers that are interested in conducting this research. Our consensus included a whole different set of constituents. So the AFMC, Medical Council of Canada, Federation of Medical Regulatory Authorities, and Medical Council, both colleges, and then via the AFMC, an invitation went out to all 17 medical schools for representation from all the medical schools. Pain, CFMS, RDOC, BMSCA, IPAC,
All the alphabets.
A lot of
people. We got really great attendance for all of the workshops, and we got all of the organizations agreed to meet with us before and afterwards for sort of free workshop consultation to get us oriented, and then to check and refine the consensus statement as it came out. Where we are now is, so we've got this thing that all these people agreed to, and we've gone around and said, will you endorse this, will you do this? And we're finding some of the same hesitation that you're describing right now. Although it sounds more like it's a discussion at a lot of these institutions about the viability, and I think that there's a pathway that still needs to be sort of cleared, in the jurisdictions in the region where this work would happen, to say, who is the government structure, right? Who do we want? How do we want to organize this governance? What is our data management facility? And we're hopeful that as we move through the final throes of the ONSORG work, our current Pan Ontario consortium, looking at the MCC and our undergraduate admissions and assessment data, that we can start to demonstrate what that might look like, at least in a provincial context, and that might turn things over as well. I think we're really well supported in Ontario, though. The Comm have been great, a great backer of this work. So
I think the researchers at each institute have done a lot to sort of explain the context of the work, why it's important, and us being good, I guess, ambassadors for data sharing. Not that there haven't been, lots of conversations or lots of work to convince people, but I think once that buy-in has been created, really what we're talking about is building and maintaining trust in the systems as opposed to just the people. And I think that's one of the core messages here. It's been very people-centered before, and I think what we're trying to say is the systems have to have trust, and once they're built, people will, that trust will continue to build on that.
I'm just gonna throw it to Amy because,
Thank you. There's a question from Dr. Vanstone in the chat, which you've kind of half answered. The ethics principles are so important. Can you give us a sense of what might go wrong ethically or how these principles can be used throughout the research process?
Ethic principles like, for example, like informed consent or respect for autonomy, if I understand you correctly, Meredith. I think a really common concern that was articulated by Reagan in the education literature was respect for autonomy and how big data research, especially in the version of learning analytics, can lead to limits on student opportunity. And so what we've often seen is the idea of predictive and then prescriptive analytics that tell you, oh yeah, here's what generally people end up happening. Therefore, based on this is what you should be doing for that learner. Now, this might be really important for us, like from an epidemiological sense, we always understand there's error associated with models, right? You're generalizing populations to people, and the big data promises that with enough big data, you won't have that error anymore. Well, we're not there yet in education, certainly definitely not in medical education. So to make that leap, for example, is one both problematic outcome risk, but also the fact that that data is being used in a way that the student doesn't realize can come back and limit their autonomy is a process risk. And so there are variations of that for each of those risks. I think informed consent is one of the more tricky ones because there are different variations of that, like presumed consent or time-limited consent, meta consent. And in our consensus, we talk about how some of those could be used and adapted so that the research does respect informed consent and at the same time doesn't impose such a significant or massive burden on the researcher to keep getting consent for every single thing that they're going to do for every single data point. To the point that Jeff made earlier, that sometimes you may not anticipate the specific question, but you can articulate things like, here's the class of questions we're interested in. Can we use your data for this purpose? And if that class of questions change, or if we think the risk associated with asking those questions change, then we come back to you to reassent you or reconsent you for that process.
so thank you for presenting today. I can see, Lawrence, why you were contacted after that paper. Because I was writing down a whole lot of questions and I realized a lot of them were tapping into sort of social and cultural aspects, but really it's like, I wanted to know the dirt of resistance and like who said what and which school was the most problematic, but I will.
So we're there is one thing we're trying.
This is just, yeah, so I'm just commenting on how the mind automatically kind of goes there, but you did invite us to discuss questions we could ask if such a database actually existed, and we have examples of some of those, right? You presented them as prior studies, so by Ash and Hamlin. So I have a two-part question, I guess. One, did you reach out to them and sort of check in with their experience in pulling information together? Like with Ash, my understanding of that is this database kind of exists, like the schools in the US are rated in some way, perhaps to benefit applicants, and then they were able to tap into that. And with Hamlin, it was a collaboration with medical council. And so in that context, the schools couldn't do anything to complain about it. The medical council owned that data. I'm just curious if you had any insights about that experience. And then I sort of a branch off of that is with what you're proposing, right? You talked about alignment. You can't, it's not just the data that the medical council has about the exams that they run. It's now data across diverse curricula and like different labels for the same things. And then what might be lost when you actually try to align something, and can you imagine communicating those limitations? So one, did you check in with people that have done this work, and then moving to questions?
Yeah, I'm gonna have the first one, Mahan's gonna answer.
No, great question though. We're really
Great questions. We didn't reach out to David Ash or Robin Hamlin directly, although the medical council board representative or consensus were able to speak to that process. Alberta, of course, is a little different in that there's only 2 medical schools in the province relative to us, and that work didn't even, like you said, wasn't extracted from those institutions. What we did do in the consensus statement, though, is engage with research experts from other fields of study that have had success in interorganizational or cross-boundary data sharing to share with us their perspectives, viewpoints, tips and tricks, et cetera, around that. So we had individuals from health services and epidemiology, Dr. Liz Wanghofer, who's at Laurentian University.
And who has done some education work linking MCC data across.
Yeah, Dr. Danny Carell, who's at Boise, and comes from the American education system, K-12 and into higher ed, that was able to do work, across periods of training from high school to university and professional schools. And a couple of individuals, Jeff Gardner and Nick Rochland, who are with Portage and the library science perspective that does probably more data sharing, data connection work than realize. And they offered our group, so each one of our workshops started with a presentation from one of these individuals that talked about their experience and that centered our consensus group around some core issues as we move forward. And they served as expert facilitators for those conversations. So not those two specific people, but we definitely pulled on a lot of expertise and then a ton of it to support this. Yeah.
To your second question, Sandra, so this has been one of the most interesting and engaging parts of our collaboration in the OnSort group, because, right, every curriculum is different. And even, for example, let's take MCAT or GPA, right? They're OMSAS variables, they come in through admissions. And yet when you look at how MCAT might get recorded in our system, in a data system, it might look very different. So some schools might break it down into 4 different individual or 3 different individual scores. Some schools might only take 1. Some schools might take, did you meet threshold or did you not meet threshold? And of course, some schools don't do it. Same thing with GPA, different weighting formulas. So even at that level, where someone else was giving the medical school the data, there was lots of heterogeneity. And then you get into clerkship, and also we had to come up with a system that was good enough, acknowledging that we're going to lose some measurement issues. So we're going to have some loss of range, and so which limits some of the reliability of our measures. We are going to have to drop some measures that are not common to all the endeavor, and modify or transform some measures. And while there are, and this is not really a talk about the OMSORC research, which we hope we might come back next year and do in more depth about how we navigated this. But those were types of things that we had to learn to negotiate and set a common set of principles by which to work from. We developed a data dictionary. Raquel Burgess actually did a lot of the work on developing a protocol for standardizing this. And even with that degree of attenuation, I think we came up with ways to do the data analysis that allowed us to preserve some of the signal and yet still detect signal in a common or conjoined data set. But again, coming back to the principles we talked about, data management policy was critical, right? A system by which to understand what we were doing with our data was critical. So we had to enact some of these principles as we were developing them as well.
You're here.
Yeah.
Simple question, what do you do with ethical consent, in something like a medical council database? In fact, virtually all of these databases are all retrospective. How do you handle that?
Learner consent.
Yeah.
Well, Mahat's mentioned meta consent a few times now, and we recognize that we benefit from some of the information that's shared with learners or test takers at the medical council early on in the process, where they actually sign documents that say, we indicate that there's a potential or possibility that your data will be used for research, quality improvement, for evaluation in certain ways, and that's part of the exchange. One thing that we really recognize is that learners know we're collecting data about the medical university in the medical school. They come here, they recognize that they're going to be assessed, that assessment will be recorded and archived and will last. So when we talk about this value appropriate data collection, this is, it's tied to this idea of informed consent, is that data that we're collecting is in service of that learner's education. And we need to, and in there's trust and there's comfort, and we can mitigate the sense of a culture of surveillance that extends beyond that education, which can be, really troublesome for learners and learners from groups that have historically been oppressed by surveillance, right? So, so as long as we're staying in that data that you're collecting for your education or for the test, that in our case has been accounted for
by these agreements.
that define.
In addition to that, I think the governance structure of Comm includes learner representation, very prominent part of that conversation. So there is a learner perspective on these questions, and does, and I think in our experience, I don't think they've been shy about saying that here are some concerns, or here are some issues that we're hearing from their constituents or the people they're representing.
That said, we don't think that the processes of consent collection are adequate currently. So we've also talked about time limited consent. So this comes out in our consent document. www.dataconnection.ca. Check it out, download the consent statement, you can read about it there. So one of the big conversations is about the inclusion of social identity data and collecting that at the university level and then sharing that. With time limitedness, we're hopeful to create opportunities for individuals that are represented in data sets to if aspects of their social identity change over time, that they can update, that there's a way that they can update so that they're appropriately represented in the data set. This is something that we need to do. So our consent processes need to advance and to move forward along with this consensus.